Hello and welcome to our webinar. For those of you who are watching this webinar, want to make you aware that this will be likely seen by most of you after the closing of the Student Assistance Center. And I want to acknowledge that it has been such an honor and a privilege to work with all of you who would be viewing this webinar in benefit to your student assistance programs. I encourage you to continue to support each other and to continue to fight the good fight for the benefit of your students and helping them to be successful in school and in life. Our topic today is eating disorders, and our presenter today is Don Mitkus. Don, I'm going to turn the presentation over to you, and thank you so much for sharing your information with us.
All right, thanks, Dale. Let me just get this going here. Okay, as Dale said, my name's Don Mitkus, and I do also want to express my gratitude to Prevention First for allowing me to be a webinar presenter for the past few years. And my contact information is at the end of this presentation. So if you do have questions about this or any presentation, do feel free to get in contact with me either via email or phone. Happy to answer any questions you might have. Our topic today is Eating Disorders 101. Eating disorders is it's a topic that's near and dear to my heart. I've been working with this population in one way or another for the better part of 20 years. And the complexity of the folks that are suffering from these disorders is enormous and not to be minimized. These folks are at some very serious risk. So what we'll be talking about today is going over what the main presentation of eating disorders are, the ones that you're most likely to come across, a little bit of the symptomology and warning signs, and a little bit about what treatment options are available and how prevalent this particular issue is. So some facts, some things to consider. Young girls are more afraid of becoming fat than they are of nuclear war, cancer, or losing their parents. Our media and social media and TV and movies have done our young women no favors in the area of self-esteem and body image. The messaging is fast and furious and impacts these young ladies on a daily basis. Not just our young ladies, though, our young men as well. Anorexia has the highest mortality rate of any psychiatric diagnosis, and we'll talk about what anorexia is specifically. But if you took 100 people that suffer from anorexia and 100 people that suffer from depression or bipolar, or et cetera, et cetera, et cetera, a greater number of that 100 people would die from anorexia than any other psychiatric condition. The issues around anorexia are quite complex, and those that suffer from it do have a significant rate of this medical issues, serious medical issues, chronic medical conditions, and or death. 90% of high school junior and senior women diet with some amount of regularity. So will in some way restrict or compensate, restrict their calories, or in some way compensate for the calories they're taking in. 9 out of 10, which again just points to how top of mind, how prevalent this particular issue is. In one study, 35,000 women just in the state of Utah suffer from an eating disorder. So in Illinois, we use Utah because we think of we have conceptions about Utah, Salt Lake City, Mormons, very proper. But even in that sort of culture where family centric as that community is, there's a large number of women that are suffering from an eating disorder. Some more facts. So the average model is 5'9" and weighs 110 pounds. The average woman, however, is 5'4" and weighs 140 pounds. So our women and our men in this there's a similar statistic for male models versus an average male. The standard for beauty is unrealistic for a majority of the population. And the lengths, and I've worked with a number of women that were in the modeling industry, the lengths that they go to in order to maintain their weight are extreme at best, with a diet primarily of coffee and cigarettes, amongst other substances, in order to maintain that weight, because they go above a certain weight and they no longer have a career, and the pressure in that industry is high to be able to maintain that particular weight. So what we see in the media, what we see in print ads, what we see in TV and movies is an unrealistic goal for 99% of women. To have a normal menstrual cycle, women typically needs between 17 and 22% body fat. Why is this important? Because those that are suffering from anorexia and are at a low body weight or have a very low body fat content will actually stop menstruating, which is one of the main signs and main criteria, diagnostic criteria for anorexia in the DSM-4. That was removed in DSM-5, and the reason for that is that not all women that suffer from anorexia lose their menstrual cycle, nor do men have a menstrual cycle. So it was discriminatory towards males that suffer from that condition. 40% of 6-year-old girls wish they were thinner, and 50% would have dieted by age 8, have engaged in some sort of diet. Where are they getting this aside from media? They're also getting it from home. They're watching their mothers and older siblings talk about how they talk about their body image issues and feeling like they're overweight, that they're dieting, and our first and best role models as individuals are our parents. So if there's a parent in the house that is consistently dieting or talking about their weight, it's going to have an impact on how their children view themselves. And body image problems in teenage boys are increasing as well. And though boys make up about 15% of the total population of those suffering from an eating disorder, they are far less likely to be identified than girls. We have seen a rise in males identified with anorexia, males identified with bulimia, but certainly in a high school setting or a middle school setting, they're less likely to be identified because many of the disordered eating behaviors they engage in are socially sanctioned or even encouraged by the adults around them. One in high school I used to work for, I had many conversations with the wrestling coach around the concept of making the weight. You get down to a lower weight, you get down to a lower weight class, and you stand a better chance of wrestling a smaller opponent, increasing your chances of winning. And some of the more extreme behaviors that these wrestlers would go to in order to get down to a weight is nothing less than bulimic purging type behaviors. And we'll talk about purging in a minute when we talk about bulimia. But these are some extreme behaviors that can have some very serious consequences. And again, socially sanctioned by the adults around them or encouraged. So what is an eating disorder? The basic premise of eating disorders, eating disorders are not about the food. They often serve as metaphors for individuals' difficulties with emotional expression or emotional regulation. So the eating disorder behaviors, whether it's restricting or purging, they're equivalent to an expression of a psychological state or expression of psychological needs. So the misnomer that boy, they're so thin. Why don't they just eat? Just have a sandwich. Just get over. You're fine. Just eat. It's not about necessarily about the food or the weight. What it is about is engaging behaviors that help them regulate powerful emotional states. That could be sadness. It could be happiness. It could be depression. It could be anxiety. That's whereas a majority of the population develop other ways of dealing with these strong emotional states. These folks have learned that controlling their food intake, or whether or not food stays within them or calories stay within them, is a way to regulate those emotional states. Not a healthy way to do it, but that's what they learned works for them. So in order to really address the eating behaviors, then you have to address the emotional states that are driving those behaviors. So it's not necessarily about the food. So you can't focus solely on the food. You got to focus on those things, those emotional states that are driving those behaviors. So the most common eating disorders, and there's some permutations amongst these three areas that we're not necessarily going to get into, but these are the three that you're most likely to run into. Anorexia nervosa, which is deliberate self-starvation or restricting of caloric intake. Typically comes with excessive weight loss. When you starve yourself, your body will shed weight, not just fats, not just utilizing fat stores, but will start to cannibalize things like muscle tissue. There's an intense fear of gaining weight. An indicator, former criteria, but now just an indicator, is absence of at least 3 consecutive menstrual cycles. And distorted body image. And what that means is someone who sees themselves as much larger than they actually are. When they look at themselves in the mirror, they don't see someone who's emaciated or severely underweight. They see themselves as fat or overweight. So there's a distortion on their perception of what they really truly look like. The thing about anorexia is can't express this enough. When you starve yourself, your body will compensate for that. If you put less fuel in your body will become more efficient in the fuel that it does get, and will start to compensate for that lack of fuel over time. This can include cannibalization of muscle tissue. That's not just your biceps and triceps, but that includes your heart. Your heart is one big muscle, and will start to cannibalize muscle tissue throughout the body. It will slow down body systems. It will the heart rate slows down, blood pressure goes down in order to compensate for the less amount of fuel that's available to the organ systems.
Don?
Yes.
We have seen a lot of news, over the last probably 10 years or so in the health field around body fat percentage and BMI. And yes. I'm wondering if some of that doesn't also play into some of these misconceptions about body image, this distorted body image idea.
Well, it's the amount of body shaming that goes on with there was a trend for a while, and I know some schools still do it, although they're highly encouraged not to, by phys ed classes or health classes posting the BMIs of the students. The body shaming that goes along with that can be very triggering, and we've treated folks that those sorts of things, along with other factors that go along, but that's something that drove them to start engaging in restricting behaviors. We see folks with, and we'll talk about different levels of care, but we see folks that have BMIs down in the 12, 13 range, which that number may not mean much, but a 12 or 13 BMI is someone who's around 5'5" and 70 pounds. it can get that severe. Part of the problem with eating disorders in general, but particularly with anorexia, is that these kids are hard to identify in the earlier stages of their disorder, because most helping systems within a school are geared towards identifying those kids that need help based on deficiencies. So, kids that are skipping classes or poor attendance or dropping grades, dropping out of activities or sports. These are all signs that someone might, that potentially needs some help, and tend to trigger interventions by the school. The issue with folks with in particular anorexia is it takes a boatload of brain power and willpower to starve yourself, to go against every instinct your body is in signal your body is telling you to not eat. These folks tend to have perfectionistic tendencies, not just about their their food intake or their body image, but also in regards to their schoolwork or their activities. These typically are kids that are academic high achievers, getting A's, B's. These are kids that are involved with 3 or 4 activities. These are, by all accounts, model students. And it's not until they get farther into their disorder, when they're more difficult to treat, that they get identified, because there's a noticeable drop in weight. There is absences due to medical complications, and those helping systems get engaged. So it's it's difficult for these folks to get identified by the current standard of identifying kids that need intervention, because they don't hit the radar. These are the kids you want in school, because they're your stars, so to speak. But in the meantime, they're starving themselves. The other difficulty that comes in with eating disorders as far as treatment is these folks are malnourished, and because they're part of the part of the body that gets malnourished is the brain, and cognitively they're not firing on all 8 cylinders, because their brain has not been fueled appropriately. So they're more they tend to be more irrational and recalcitrant when it comes to what would normally be an effective therapeutic intervention. So there's a number of factors that go along with that's why I said earlier, these are complex cases, and there's a lot of things to take in consideration with these folks that you wouldn't have to for someone that's suffering from a depression or bipolar or substance use disorder. So bulimia nervosa typically is secretive binge eating followed by purging, overly concerned with body shape and weight, feeling of loss of control during the binges, and the guilt and shame that comes along with after that it results in the purging behaviors. Now these are folks, they tend, unlike anorexics that tend to lose a large percentage of body weight, bulimics tend to be of normal, if not slightly over ideal body weight. When we talk about purging, we typically think of purging as vomiting up food that's been eaten during a binge. However, there are other forms of purging that occur with those that suffer from bulimia, and that the ways of trying to compensate compensating behaviors for that caloric intake can include use of laxatives, diuretics, or diet pills. There's an intense fear of gaining weight. They can another form of purging behaviors is excessive exercising, and they also tend to suffer from a distorted body image. The types of bulimia has different risks involved with it, medically speaking, than anorexia does, because the bulimic is getting fuel into the body, but the act of purging, depending on the compensating behavior, can have other types of serious consequences. Those that induce vomiting on a routine basis can wind up suffering from esophageal varices, or the throat starts bleeding, which can get incredibly dangerous very quick if not identified early. So someone who has vomitus with blood in it, it's a very serious warning sign. Abusing laxatives or forcing your body to push food through the system quicker and eliminate it through the laxatives can be quite dangerous, because the laxatives can reduce your body's natural digestive cycle to the point where the parts of the intestine, colon, can be paralyzed or even become necrotic. Diuretics, when you start eliminating water from the body, you can mess with your electrolytes, sodium levels, and diet pills can be dangerous to your heart. Excessive exercising. When I say excessive, we have folks that will exercise 2, 3 hours, 4 hours a day, every day, in an attempt to purge any caloric intake that they put into the body. Binge eating disorder, which is binging, again with that feeling of loss of control, but without the purging that comes along with it. Also suffer from distorted body image, typically overweight. And by far, this is the most common form of eating disorder. But again, we remember that eating disorders are not about the food. The binging, with or without the purging, is an attempt to control an unmanageable emotional state. So feeling of loss of control, which can be triggered by a number of things, triggers the behavior in a way to try to control that emotional state or alter it. So how prevalent are these disorders? Honestly, the existing research is often conflicting. Research into eating disorders is actually very, very new compared to other disorders. The first study of bulimia wasn't conducted until 1981. So we have, whereas we have 30 odd years of research available to us on this particular condition, we have 60, 80 years on alcoholism. We have about 100 years on depression. So this is a relatively young area of study. But as far as we can, from the studies we do see, and there's a range. So anorexia nervosa is prevalent in 0.5 to 1% among females in late adolescence, early adulthood. Bulimia is more common, 1 to 3%. And binge eating disorder in the general population is somewhere between 0.7 and 4.0%. And again, these ranges, that's a pretty wide range for all three of these, and it's because the studies vary in their conclusions or their prevalence rates. So this is from a meta-analysis by Keel in 2005. In another study from Gordon in 2003, the subclinical eating disorder prevalence are estimated as high as 13% of the population, meaning that it's rather than eating disorder, it's disordered eating, which is those that are on the diet roller coaster, on a diet, off a diet, on a diet, off a diet. Those that are engaging in behaviors that are perhaps over exercising or taking diet pills, but not in excessive amounts. These are what would be considered behaviors that are possible indicators of emerging eating disorders, but don't meet all the diagnostic criteria as of yet. So heading in that direction, but not quite there yet, is quite high. 1 out of 9 people. It's pretty significant. So some signs of an eating disorder, observable signs. Again, we mentioned this before: menstrual irregularities, reduced body temperature, irregular heartbeats, general muscle weakness, So these are things that with that it's important to have your school nurse be oriented and become familiar with the signs of an eating disorder, because they're the ones who are potentially going to pick up on these particular symptoms. Tending to eat alone or eating in isolation, or if in a group that is eating, tends to either not eat or will push their food around their plate. But eating with others for those with an eating disorder, tends to be very uncomfortable, and they tend to avoid those situations. Pale, dry skin, thin or dull hair, impaired alertness. So again, we're talking about those that are restricting their fuel intake. So so their alertness and their cognitive ability is going to be impaired. Red, irritated mouth, eroded tooth enamel, and these are things that we tend to see in those that are engaging in self-induced vomiting. Reduced sensation of pain, or verbalizing concern, repeated verbalizing concern about body size or body image, and in general anxious about food. So these are the folks that when you talk about a social situation or going to a social situation where food or eating is going to be going on, and they tend to avoid those situations, or become very anxious when they have to be in those situations. Excessive exercise, perfectionism, mood swings and lability. Your irritability is very common. Irritability that can, in later stages, border on paranoia, is very common for those with an eating disorder. Low self-esteem, withdrawal, feelings of isolation, depression, or irritability. You start to see these things as the disorder progresses, and that's the issue, is that you tend to see these once someone has actually developed an eating disorder, a true eating disorder, and the disorder has become more pronounced or advanced. So this is later stage stuff that will, this is when folks tend to come on the radar of school personnel, is when you start to see these changes, the withdrawal or the depression, or the severe irritability, or lack of cognitive ability that used to be very robust. So some health problems, we talked about some health problems, but some other health problems that can occur because of an eating disorder include stunted growth, even delayed puberty, depending on how early the eating disorder starts. One of the phenomena that we've been seeing is that eating disorders, true eating disorders, not just disordered eating, but true eating disorders, are starting at a younger and younger age. To the point where an organization that I work for, we started a child eating disorder program, a child track in our eating disorder track in our child program to address those children. And again, children are between the ages of 7 and 12 that are dealing with some very severe restricting or even purging issues. So that, again, the earlier they start, the more likely it's going to impact their development physically. So they could have stunted growth, they could have delayed puberty, they have a weakened immune system, hypoglycemia, low blood sugar, which can lead to dizziness, fainting, passing out, permanent loss of bone mass, more fragile skeletal structure. Hair growth on the face and body is a outward sign. It's called lanugo hair, and part of the body's reaction to the low body fat content is the body starts generating hair on places where hair doesn't normally grow, especially on girls, to help retain body heat. One of another clear sign of someone that might be dealing with anorexia in particular is the wearing of baggy, warm clothing in inappropriate weather. So it's relatively warm out, springtime is here, and they're walking around full hoodies and jackets because they're cold all the time. And they're cold all the time because they have very low to non-existent body fat, which helps keep us insulated. So the body, for those that have low body mass, will start to, again, the human body is an amazing thing and adapts to many different circumstances. But one of the things that it will do when your body mass, your body fat goes below a certain percentage, it will start generating hair in places that it normally doesn't. Kidney and liver damage. This is in particular for those that are engaging in certain types of purgative behaviors, especially use of laxatives, diet pills, and diuretics. These can, over a long period of time and with enough overusage of these types of medications, can cause damage to the kidney and liver. Anemia, which is low red blood cell count, fertility problems. Like I had mentioned, could be delay in puberty, but your reproductive system is highly the reproductive organs have a high lipid content or a high fat content, and it needs that particular your body fat to be at a particular minimum in order to be fertile. And of course, I know this is extreme cases only, but death can occur. It's not unusual for those that have BMIs of 12 or 13 to have an accompanying heart rate of 30 to 40. The thing about the heart is that the heart also, your muscles require fuel in order to work. And one of the nutrients that's really key in that is potassium. So if you're not eating, you're not getting any potassium intake, and you find potassium, of course, in things like bananas or potatoes and other very common foods that are avoided by those that are trying to restrict their caloric intake. Potassium is the fuel, one of the primary fuel sources for your muscles. Again, your heart is one big muscle, and if it doesn't have fuel, it's going to slow it down to compensate for the lack of fuel. And at a certain point, when the heart rate gets below 40, your heart can just stop. So cardiac issues are a very big concern. When someone engages in regular purging behaviors, it can induce an irregular heartbeat. And the thing about irregular heartbeat is that, again, your heart can just stop if the irregularity is significant enough. So these are all, when you mess with your body's fuel consumption, it's going to result in some potentially very serious consequences. So again, I can't encourage you to not minimize these issues enough, because it can lead to some very, very serious consequences in a relatively short period of time. When we assess folks, one of the things we do is we have them do blood work to see where those values are at. But if that blood work is more than 2 weeks old, it's not clinically significant, because those values for someone who is starving themselves or purging frequently can change very rapidly. There are things that we often see in conjunction with an eating disorder. So if you have someone who comes to your office that is dealing with one of these issues, it behooves you to explore the possibility of an existing eating disorder as well. So major depression, bipolar disorder, anxiety disorders, particularly OCD, I have a high correlation with eating disorders. Personality disorders, because many folks, a significant percentage that develop serious eating disorders have some form of traumatic history, some form of trauma in their history. So that significant trauma is also a potential predictor of development of a personality disorder as well. Substance abuse, we tend to see substance abuse more in conjunction with bulimia, because again, they're using some form of purging to compensate for caloric intake. So abuse of stimulants, cocaine, alcohol are all more common with bulimia than with anorexia. And then deliberate self-harm or non-suicidal self-injury is another potential indicator of an eating disorder. We see about, for those that require a higher level of care for an eating disorder, we see about a 40% co-occurrence between eating disorders and non-suicidal self-injury. And oftentimes they will develop the issues is the goal of the behavior related disorders like self-injury or substance abuse is many of these folks are trying to regulate a powerful emotional state. So if they get themselves in a situation where they can't engage in an eating disorder, can't engage in their substance use, can't engage in their self-injury, many times they will develop issues with these other behaviors in order to maintain that level of emotional regulation. So they might start abusing a substance, they might start self-injuring if their eating disorder is found out and is being worked on. It's for some folks, it's you can wind up playing clinical whack-a-mole. You push one down and the other behavior ramps up. So you have to be very cognizant and mindful of getting a good history and a good assessment to see if these folks have been dealing with these other issues previously, because if they had dealt with these or exhibited these behaviors previously, there's a very high likelihood that if you work on the eating disorder, that these other issues will rear their ugly head. So this is the SCOFF. Now, the SCOFF is a questionnaire that was developed in England by Morgan, Reed, and Lacey, and it's a good kind of brief screening for eating disorders. You may be familiar with the CAGE, which is a quick screener for substance use, but this is geared towards eating disorders. 5 questions. A yes on any of the 5 is a good indicator that someone should be referred for more thorough assessment of whether or not they have an eating disorder and what their clinical needs are. So do you make yourself sick because you feel uncomfortably full? Do you worry that you have lost control over how much you eat? Have you recently lost more than 14 pounds or 1 stone in a 3-month period? 1 stone is equivalent to 14 pounds in Old English measures. Do you believe yourself to be fat when others say you're too thin? And would you say that food dominates your life? So you can see from our discussion of anorexia, bulimia, and binge eating disorder that these questions kind of zero in on some of the salient diagnostic criteria. So again, a yes to any of these questions, any of the 5, or certainly if more than one is a yes, would be a good indicator that that person needs a more thorough assessment. So when treating an eating disorder, it's not just as simple as going to a therapist, because you've got these medical issues that are potentially extant as well, and it really does take takes a village to raise a child. It takes a team to effectively treat an eating disorder. So you need a psychiatrist that knows their way around an eating disorder. Not all psychiatrists do. You need a therapist that knows how to work with eating disorders and have a specialty in that area. And again, not all of them do. You need a dietitian to do meal planning. These are folks that have developed their own distorted meal plans over the course of months or years. You need someone who knows food and knows nutrition to get them on the right track, get the right fuel in their body in a mindful way, because you can't just send them to the fast food joint to get a couple of burgers and start and a milkshake and say, hey, start putting some weight on. That can be medically dangerous. So you need a dietitian that really knows their way around these issues, and one that knows eating disorders, again, because there are a lot of dietitians that have absolutely no or very little training on how to work with an eating disorder. They know a ton about diabetes, but know nothing about eating disorders. You need a primary care physician, because again, this, even though a psychiatrist is a medical doctor, their realm is neurology, and brain science, not the rest of the body. That's not their specialty. So you really do need a primary care physician involved in their treatment to monitor lab work, to treat medical issues that may have developed because of their eating disorder behaviors. And the role is there, there has to be a continuity of care. There has to be communication between all of these team members, even though they may be in different offices, in different towns. It's vitally important that there are releases of information signed between all the treatment team providers to each other, so they can all discuss how the treatment for this particular individual is being carried out. Because again, these folks with eating disorders are incredibly bright, and incredibly manipulative. And if given an opportunity, will engage in splitting between their treatment team providers. We'll tell one thing, one the other, and if they're not talking to each other, there will be the treatment will be disparate, and will not be coordinated, and will not be effective. So, according to the American Psychiatric Association, there are 5 levels of care, 5 levels of intensity of treatment for an eating disorder. It starts with the lowest level is outpatient, and that's again, that treatment team we talked about, which is having an outpatient psychiatrist, an outpatient dietitian, outpatient therapist, and a primary care provider. Some of you're seeing probably on a weekly basis, the therapist at least, the physicians, the psychiatrists in primary care probably less frequently, but with some on a regularity, and the dietitian most likely on a weekly or bi-weekly basis. That's outpatient. For those that are unable to make progress, or behaviors worsen in outpatient, the next step is intensive outpatient, which is a structured program where they're going someplace 3, 4, 5 days a week for 3 to 5 hours a day, where they're working with the treatment team in that program, but it's also providing a structure around their treatment, so they're better able to make changes in a monitored environment. Partial, meaning partial hospital program, is the next level of care, where it's the intensity, the structure. It's still an outpatient program, but the structure is more significant, where people are going anywhere from 6 to 12 hours a day, 5 to 7 days a week. Very intensive, very structured. Typically, they're eating 2 or 3 meals and plus snacks with that program every day, working with a dietitian on a daily basis, therapist on a daily basis, seeing a psychiatrist several times a week, and having a medical professional with closely monitoring their progress and their medical symptoms. But they're at home in the evening to be able to put into practice some of the things that they're learning in program during the day. These are for this level of care for folks that cannot change their behaviors otherwise in a lower level of care. The next level is, this seems out of order, but it isn't, is residential. Residential is where someone whose recovery environment is not supportive enough of recovery, of making changes, they're been unable to change the dynamic of their behaviors enough in a lower level of care, like partial hospital or intensive outpatient, that they need to go someplace to get that level of help. Now think about outpatient care. Outpatient, you can see someone, an outpatient treatment team for months or even years. Intensive outpatient and partial hospital tend to be measured in a number of weeks. 2, 3, 4, 5, 6 weeks is a typical range of a length of stay in a program like that. Residential tends to be 3 weeks to several months of treatment. where they go someplace to a very recovery-focused and highly structured environment to help build a solid foundation for their ongoing recovery. And finally, there's acute inpatient care. Now, acute inpatient care tends to be short-term. The lengths of stay could be days to a couple of weeks. But it is the most intense level of care because it is in a hospital-based setting where typically it's very restrictive, tends to be on a locked unit, and it's for those folks that have some medical issues and complications that from their eating disorder behaviors that are creating safety issues, potentially serious safety issues for that individual. So these are folks that may need to, that are such a low body weight, 60, 70, 80 pounds, that you have to carefully and mindfully reintroduce nutrition to their bodies, because if you put too much fuel in too quickly, you can trigger what's called refeeding syndrome, and that can be medically complicated, if not medically dangerous or fatal. So you have to be for those folks that need to be brought up carefully to a medically stable weight, or those whose pattern of behaviors are so extreme that they need to be in a very controlled environment. Those that are purging 3, 4, 5 times a day. These are, those are folks that need to be in a acute inpatient setting to get those more extreme behaviors stabilized. And then when someone is done with a particular level of care, the expectation is they step down through the continuum. So for those that need acute inpatient care, they may step down to a residential or partial hospital program to step down the level of structure and not throw them back into their triggering situations too quickly. It's kind of a setup for failure if you do something like that. So you need to be careful and mindful how you provide a continuum of care, and with the goal being, of course, to step down to outpatient from a partial or intensive outpatient program, from outpatient and then outpatient, hopefully just to maintenance. So how do we determine what level of care someone needs to be in? Again, it's medical status, suicidality. So between medical status and suicidality, those are the things that are going to tell us if there are safety issues. If there are safety issues extant, then someone does need to be in an acute inpatient setting. If there are safety issues that threaten their safety, either medically or psychiatrically. Weight or BMI. For those that have BMI of 16 or under, they also need to be inpatient because they're not likely to respond to the interventions that occur in a residential or partial hospital level of care, and they're likely to, if they don't have abnormal labs, more likely to slip into a crisis state, medically speaking. It's determined by the co-occurring disorders. What else is going on? Their ability to control their compulsive exercising, their frequency and type of their purging behaviors. For those that are abusing a large amount of laxatives or diuretics, for instance, those folks need to be in a hospital setting, at least initially, to get their body systems functioning with, self-sufficiently and on their own without the aid of the laxatives or the diuretics. Can be determined by the recovery environment. It is not unusual. Unfortunately, it is not unusual for us to see a second-generation eating disorder. We've even seen a couple of third-generation eating disorders where the identified patient is in a family system that is not well, where a parent or parents are engaging in disordered eating or eating disorder behaviors, which makes it very difficult, if not impossible, for someone to find recovery when they're in a living environment where someone is engaging in their behaviors and triggering them on a daily basis. So someone whose recovery environment is very poor might very well need to go to a residential program in order to get started on down the road of recovery. It can also be determined by the geographic availability of a treatment program. Programs that specifically treat an eating disorder can be difficult to find if you go outside of a metropolitan area. We're in the suburbs of Chicago, and people have a number of choices when seeking treatment for any level of care for the treatment of eating disorders. You go south of I-80 though, and the number of programs that exist, structured programs that exist between I-80 and St. Louis is one. There is one in Peoria. There are only a handful of outpatient therapists that know what they're doing with an eating disorder. And again, I can't emphasize this enough. You need to, if you're engaging the therapeutic services or making a referral for students to get help with an eating disorder, it's imperative that you determine whether or not that person has experience working with eating disorders. There are some that will say, "Oh yes, I'll work with an eating disorder," but don't know what they're doing with them, and that can get someone in a tricky situation. Because again, these folks, their clinical presentation can be quite complex. So with that, again, if you have someone come in your office that you're concerned that, or a friend expresses a concern to you about another student that might be suffering from disordered eating or eating disorder issue, it is imperative that some form of intervention is done. Could be something as simple as having the social worker bring them in or the nurse and asking them the questions on the SCOFF. And if there is something going on, to engage the parents to get that kid some help. These eating disorders are incredibly serious. So I would encourage you to give it your best effort to get that person connected with appropriate care and services. Again, this is my contact information. Do feel free to shoot me an email or give me a call if you have any questions about this or any of the programs that we've provided here in the webinar series for the Student Assistance Center. Thank you for your time, and take care.
Thank you, Don. I appreciate the information. I hope it was beneficial to all of you watching, and we have thoroughly enjoyed your presentations, Don, throughout the years, and we appreciate here at the Student Assistance Center, we appreciate your knowledge and your expertise on everything that you have done for us. So thank you so much, and have a good day.